Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing the National Indigenous Kidney Transplantation Taskforce. You can read more about this in the new supplement published in the Medical Journal of Australia on the 16th of October 2023. My special guests are Professor Jaquelyne Hughes and Miss Kelli Owen. Jaquelyne Hughes is the Taskforce's Deputy Chair and a Flinders University Professor and nephrology consultant. Miss Owen is the National Community Engagement Coordinator for the Taskforce and has lived experience of a kidney condition. Professor Hughes and Miss Owen, thank you so much for joining me today.
Hi Sam, thanks very much for the opportunity.
Thank you, Sam.
Professor Hughes, I'll start with you. What is the situation at the moment in terms of recorded rates of kidney failure among Aboriginal and Torres Strait Islander Australians?
First of all is recorded rates, second is kidney failure, and the third is Aboriginal and Torres Strait Islander people. So I'll start with the last bit first. I'm proud to be a Torres Strait Islander woman. I belong to the Wagatagam people of the Near West Torres Strait, and it's an absolute privilege and responsibility to be a leader within the National Indigenous Kidney Transplantation Taskforce to facilitate the business of improving access to transplantation. Transplantation means that a healthy, viable kidney organ, which does all the filtering work that our body needs, plus other endocrine functions, is gifted from a person whose kidney works just fine into another person who has kidney failure. And that means that they don't have enough of that kidney function within their own body. But we know that by giving extra kidney function in a different way, people can have a stronger body and a stronger health. So kidney transplantation is literally an explanted organ from a person with kidney function to a person who doesn't have enough of their own. And it's a really important modality. It improves people's survival in actual days and also quality of life, even beyond what people report about the survival advantage from treatments like hemodialysis or peritoneal dialysis. So the recorded rates of kidney failure in Australia, we get that data from the Australia and New Zealand Dialysis and Transplantation Registry, which means that when a person is regarded by their clinician as needing to have survival treatment with either dialysis or transplant, they get recorded onto that registry. So it's a really important information system. NIKTT has been around since about 1964, which for that context means it preceded the last referendum. So for the whole time that we've actually had national statistics in this country that actually regarded us as first people and people, we actually have a story within NIKTT that tells us about the development and emergence of kidney failure where people have been able to access treatment. And what's been really extraordinary over the last 50 years in Australia is that Australia are international leaders in the provision of both dialysis and kidney transplantation. But the parallel story to that there's been an emergence in kidney failure amongst Aboriginal and Torres Strait Islander people, but not a similar emergence into the access of kidney transplantation. So that data repository for NIKTT is really important for Aboriginal and Torres Strait Islander people to have a voice about their conditions and the health systems and what we need to improve our lives.
And Miss Owen, as the National Community Engagement Coordinator for the Taskforce, how do you see the situation at the moment from a community perspective?
So having been on dialysis in a unit, our people are overrepresented on these machines, and we're actually not receiving the transplants at the same rate as non-Indigenous people. We don't want to be on the machines. This is a lifestyle I wouldn't wish upon anybody, let alone our future generations coming through. And, it's about looking at how we can stay off the machines.
And Miss Owen, can you talk me through the challenges that Aboriginal and Torres Strait Islander people face when accessing renal services?
You need to, that's multifaceted. In terms of my own journey, it was trying to keep employment and raising kids because you're having to access treatment 3 times a week for up to 5 hours a day, the questions of how is the mortgage going to be paid or, how you're going to put food on the table and being able to keep employment because, we're living below the poverty line as it is. But moving off country, away from your family, away from your support systems to be able to access treatment that's going to save your life. You know, you need to be looking at accommodation, whether where you're going to be staying at a metro or where the dialysis unit is if you can't get dialysis on country. But sometimes that looks like keeping 2 rental places to be able to keep that accommodation. It's transport of being able to rock up at a dialysis unit. It's entering a hospital system that is not culturally safe for our people, you know, in terms of our language and the medical jargon that's used for us to understand, or even education and prevention. And this is before we even look at getting waitlisted to be put on, the active list for a transplant. So there's a lot of barriers that our people need to overcome and navigate through to get access to save our lives.
And Professor Hughes, Kelli raised the issue of cultural safety there. How do you see things from your perspective in terms of cultural safety?
So cultural safety is really important to the lives of First Nations peoples. It's definitely important for healthcare systems to operate with cultural safety in Australia, but also there's broad international evidence that that's the case as well. So cultural safety is the ability of people of First Nations backgrounds who are in minoritised positions within care to have safety without repercussion to comment on their care so that they achieve good health outcomes. And this is not really the history of this country to be able to comment on how we are received, how we are in these places. And these speaks to those determinants, that Kelli just talked about the barriers of, people live within their families and intergenerationally coming into this overwhelming condition, which is kidney failure. So cultural bias was actually a requirement of the National Indigenous Kidney Transplantation Taskforce in our commissioning from the federal government, that we had to examine how we operated in the lens of cultural bias that was a critical factor in these outcomes for kidney failure. So yeah, it's absolutely important. It's just so important, not just in the areas of kidney health specialty, which is the area that I practice, but in every healthcare system where Aboriginal and Torres Strait Islander people intersect, and for all clinicians operating with Aboriginal and Torres Strait Islander people. And just for that perspective, every piece of land and associated waterways in this place called Australia is Aboriginal and Torres Strait Islander land, which means that cultural safety isn't the purview or the requirement of some clinicians or some services, it's actually the requirement of all services. So I'm really proud through the National Indigenous Kidney Transplantation Taskforce, with our relationships across multiple states and territories and different health systems, this has been something that we've been working together collectively on.
In 2018, the Australian government funded an expert panel to undertake a review into the hurdles and service gaps faced by Aboriginal and Torres Strait Islander people receiving treatment for kidney disease. Professor Hughes, could you please talk me through the history of the setup of the task force and where things are at now?
So I think the history comes a long way before 2018, Sam, particularly. So, just for that context that I said in the opening, that there's been 50 years of really fantastic experience and wisdom amongst kidney transplantation service provision in Australia. So we've got that really strong biomedical focus that we know how to do that sort of technical treatment around it. And yet there'd been a sustained inability to be able to make kidney transplantation accessible to Aboriginal and Torres Strait Islander people. I'm not a transplant physician. I work mainly in the areas of chronic kidney disease and for caring for people on dialysis, but I was asked to come and join the expert panel because of my experience as a First Nations woman and in my area of specialty. So the history of the setup is clinicians needed to have a better way to engage with Aboriginal and Torres Strait Islander people and around the business of Aboriginal and Torres Strait Islander health advancement beyond the scope of nephrology. So I'm really just proud. This is a really demonstration of population health around kidney disease for Aboriginal and Torres Strait Islander people, which moves beyond that sort of technical framework that we'd had before. So the history of the National Indigenous Kidney Transplantation Taskforce for the time that I was involved was we had a really important meeting of many Aboriginal and Torres Strait Islander people with the lived experiences of kidney disease, kidney failure. That was called the Indigenous Patients' Voices Forum, which we'd set up at the nephrologists' annual scientific meeting in late 2017. that was co-funded by pharma, by industry, but also supported by Kidney Health Australia. And there were nephrologists in the room. It actually happened to be hosted on Larrakia country where I worked, and that wasn't an accident because as part of the organising committee, the Darwin clinicians organised for that to happen. And so the legacy of that work is now we've got consumers at every national conference that we've had since then, because this is the power of connecting clinicians to the people that we provide care for, that we're advocating for care, to be able to create really breakthrough ways of working. So shortly after that, and it was in Minister Wyatt in the former government's time, where we took it to him that as a collective we wanted to move forward, to stop being in a space of inertia. We needed to make a difference. We were called to be making a difference. We were asked to be accountable about the care that we provided that was a bit stuck around transplantation. So we went to him. I was actually asked by Stephen McDonald, the chair of the National Indigenous Kidney Transplantation Taskforce, and we were sponsored by the Transplant Society of Australia and New Zealand. So we developed a collaborative that went together to Minister Wyatt to said, what could you do to help us? So he gave us that first tranche of support so that we could compile an export panel together and write that first performance report. But, there were some things that were going on at the same time, Sam. So this was the agency of Aboriginal and Torres Strait Islander people to make best value of the time that we have with the microphone that we have to talk about it in other spaces. But there'd been a lot of work from Aboriginal people. Sovereignty has never been ceded. We're always talking about arid health advancement, even in the challenges that this health structure is. There was also funding that Minister Wyatt, through that government, had been able to be working on towards funding assisted dialysis in very remote country. Comes back to what Kelli was saying. Before November 2018, that wasn't so readily available. So there were a few things that were coming up, and the other parallel to that was I just wanted to honour the Aboriginal and Torres Strait Islander the health organisations through the ARCO sector about their advocacy. So it wasn't really a surprise to the federal government about our advocacy, because we were moving with a community-controlled focus, partnering with clinicians to make this difference.
And Professor Hughes, how much of a game changer is this task force in terms of data collection, improving equity and reducing cultural bias?
Oh, I think that's a really good question for Kelli to take the lead on the answer for. But I will say, as a clinician, it is so powerful for the clinician community when patients that we care for endorse our practice and endorse the need for practice change. And I'm so proud that we've been able to facilitate that through the voice of our community panel, of which Kelli Owen has been the lead for. We didn't design that we'd have that when the National Indigenous Kidney Transplantation Taskforce was initially constituted, but it quickly came to the fore that was absolutely needed. So I'm really proud to follow the lead of community who have a voice and who require to be listened to. And when we listen and work together, we've been able to make some really important movements through with the National Indigenous Kidney Transplantation Taskforce. The work's not finished. We've asked for our second tranche of funding. We're hoping to hear from the federal government about that, because there is more work to do. But I'd be interested to see, how Kelli responds to that answer, Sam.
And Miss Owen, how do you see this task force changing things?
Previous to NIK being established, we didn't have a place where we can go to sit and talk about how we can actually solve them from a lived perspective. Our voices are actually being heard, they're being listened to, and they're being actioned. So instead of us all trying to advocate separately, we've got a national network across the country that, very similar themes and problems that are coming out in different regions, but being able to bring it back to the task force and tell them what's happening in that region, and being included even within our cultural bias of specific examples of what's happening. It's their voices within the cultural bias document.
And Miss Owen, can you please talk me through the Indigenous reference groups and the importance of those groups being a safe space?
Being able to have we call it a black space. It's a brave space where our people are able to get a check-in with our spirits first before we get down to business. There's a loose agenda that'll get tabled and we'll get through in our own time, but it's a place where we're able to talk about these solutions that we spoke about previously. It's coming from our lived experience point of view. It's using our own language and our own humour, to get through a meeting with some really serious stuff that we need to talk about. But it's actually working with the transplant unit to bring about a transplant response change. That, we can't do this work by ourselves. We've tried, and, clinicians can't do it. So coming together and talking about, here are the themes that we've highlighted that we need to work together on. We've been very lucky here at Adelaide, at the Royal Adelaide Hospital, to have a commitment to work with us for 5 years to start addressing some of these themes as lived patients. We can do better, and that's been proven. We've still got work to do, just out of 8 themes, we're addressing 3.
And Professor Hughes, how will the Taskforce help improve access to renal treatment and information?
So the Taskforce is a structure that enables us to come back to the key things that we've agreed to work on. So, you said in your introduction that the remit from our funding for the National Indigenous Kidney Transplantation Taskforce was first that we made a task force. So we've got a secretariat. So Kelli and I are on the secretariat at the Operations Committee level with others. The secretariat and the operations group does the legwork to facilitate key business around granular data. So we know about where the starting data was to see how our interventions improve that change, so we can see that with data. We created a space. We were required to and proud to support looking at cultural bias. That really showed us that there's not a lot of data on actually the healthcare system within a renal transplant space that is done on that. So that tells us now that we need to give ourselves permission to talk about racism in healthcare, systematic racism in healthcare, institutional racism in healthcare, in order to there not to be racism outcomes of care. So that's been really important. So that's just shown us that there's work to do going forward. And then we needed to not talk about improving the healthcare system without Aboriginal and Torres Strait Islander lived experiences. So that's where Kelli was the lead for those community networks and the importance of formulating Indigenous reference groups. And then the fourth thing is who's going to make the difference? Because we know we want to make a difference. So that was a really important part of the award from the federal government. I think we got $2.3 million and we made it last 3 years because we had that COVID interruption. But what we were able to do with that was we carved out $1 million for regional innovative practice to actually make the difference to get people waitlisted. And that features in the supplement and it features in our major report. And so what this tells us so importantly is that clinicians and patients are already working together to make the difference. But we have to be committed to change and accept how change works in order to actually change the numbers from difficult access to improved access. So those were the equity and access sponsorship schemes. By us getting the gift of $1 million, we could rapidly mobilise that out into funding. We had the secretariat to support clinicians who are busy about their business to actually see that those projects were developing and that we could report on them. That's an amazing advance in terms of innovative practice for chronic conditions in Australia, because kidney disease doesn't affect one community, it affects all the Australian economy. And for accessing kidney transplantation, I work in the Northern Territory. We don't have a transplanting unit here, so we've got to send someone into state to do that. So we have to have systems that work across state and territory borders, and it means that we need to have clinicians on the receiving end and the delivery end actually working at, the high quality level of culturally safe practice while also providing that, technically very high proficiency care. This has been so amazing, and I've been so proud to be part of innovative practice change.
And Miss Owen, from what you're hearing on the ground, having set up the Indigenous reference groups and leading the national engagement, what kind of feedback are you getting, and are you hopeful for the future?
So we really want this to be available to all transplant units. We want to be able to increase our workforce and have First Nations people leading these kind of projects within their hospitals. To be able to have your voice heard and to actually see change from the other end and not just as a patient is really re-empowering for our people to know that we're at the table having these conversations and things are actually getting done. So they're vital for us to be able to move forward.
And with the supplement now published in the Medical Journal of Australia, Professor Hughes, what's the importance of highlighting this important work and keeping it in the national conversation?
So I think what's important to know is that kidney health is such an important priority for so many families and so many health sectors in Australia, but it's never been included on the metrics for closing the gap. So there's just been that disconnect. So what we've been able to show with the National Indigenous Kidney Transplantation Taskforce speaks into the federal conversation in a different way than we've had before. And closing the gap has been there since 2008. So I think that's really important. The second thing is about where knowledge is archived, because this is really important knowledge of what was needed, who was involved, how we committed to change, how we're accountable for the change that's happened. That's a really important epistemology. Okay, epistemology is really important in the biomedical system in terms of knowledge recording. That's called the journal archiving system. So we're really proud to have a partnership with the MJA to have a supplement, and also to have it open access so people don't have to pay per view. Because this is part of our accountability to people, that if we say we need a change and we've proposed a change, people should be able to look at it and assess that. And we should be able to be challenged on it to say, why didn't you do more? And we go, okay, we can answer that question. Or, wow, you achieved more than we expected. We can answer that question. And then the other thing about that is the epistemology, the dissemination of knowledge amongst Aboriginal and Torres Strait Islander peoples. We don't create something so that one person knows about it. We create knowledge so it can be shared. So there's collective wisdom, but also collective health improvement. So it's been a definite strategy throughout the National Indigenous Transplantation Taskforce that while we're reporting to our funder, which is the federal government with our annual performance reports, we're also reporting to the health system through our taskforce members and leaders. We've been reporting at our national conferences around nephrology medicine, and we've been reporting with the networks and the newsletters that Kelli's been leading. We have a social media presence, and we also have a web presence, and proudly supported by the Transplant Society of Australia and New Zealand. So it really is important. This is about the distribution of knowledge from publicly funded. Government publicly funded. We pay all our taxpayers into it. And so we should be accountable as a government-funded task force to be able to show what we've done for it. And similarly, we should be able to ask our service providers to also be accountable for their position in it right now, to take this forward about translating that impact going on into the future. We've done some work to show that we've improved the access to waiting list for kidney transplantation for Aboriginal and Torres Strait Islander people. We don't yet have enough time to show that we've actually improved actual transplantation rates. That's why we're insisting that we need to do more work for this. And Kelli will say, the business now is who's going to be the peak body to govern and support this going through, so that we're not got disparate voices which are unjoined, but we're actually working collectively together moving forward.
And there is a special cover today because of the supplement. Can you talk me through the cover?
First of all, we have the message sticks. So the message sticks were purchased to actually have at our Indigenous reference groups. It's to hold the stories and the voices of our people. It's also a way in which to kind of keep the formalities happening within a meeting. So there's only one person speaking at a time. But it's bringing that, what we were wanting to do was bring all the message sticks from all the Indigenous reference groups back to federal government upon completion of our project. The kangaroo skin is a representation of my journey across Australia, actually. And I have burnt into the skin the story. And the Warrup, Jackie, I'm going to hand that one over to you.
So that's the beautiful drum of the Torres Strait. It is the voice of the Torres Strait. And you tap the end and it reverberates around. It's a literal communication and a voice across the region. And so I just wanted to honour Uncle Robert Sagigi, a man who supports kidney health in his region and whom I'm proud to work with, but also my dad, Patrick Wapp, who was a linguist and a teacher, and he knows stories from time immemorial, to make sure that when we talk about the National Indigenous Kidney Transplantation Taskforce, this actually is the literal voice of Aboriginal and Torres Strait Islander people about creating change. And what really strikes me is these aren't symbolic. These are actually, we're carrying the voice and messages. And in June when I was down in Canberra at Parliament House, it's such an honouring space to be standing beside the Barunga bark petitions and the Yirrkala bark petitions. These are the messages of leaders of our country requesting change. And we haven't listened and stood still. We've listened and moved together. And that's a tremendous thing for us all to honour in the healthcare system. And our commitment to be transparent with the MJA supplement is so that other spaces of the healthcare system can also transform by learning from us. So we are generous to each other to share what we have known, because everyone should move forward with culturally safe health outcomes, and the Aboriginal and Torres Strait Islander people rightfully deserve optimal health outcomes in this place, our country.
Professor Jaquelyne Hughes and Miss Kelli Owen, it's been a pleasure to interview you both today.
Thanks very much for the opportunity.
Thank you, Sam.
My special guests have been Professor Jaquelyne Hughes and Miss Kelli Owen. Professor Hughes is the National Indigenous Kidney Transplantation Taskforce Deputy Chair, a Flinders University professor, and a nephrology consultant. Miss Kelli Owen is the National Community Engagement Coordinator for the Taskforce. You can read the supplement in the 16th of October 2023 edition of the Medical Journal of Australia. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.